Okay, so this is our substance use roundtable presented by Abby, Cassie, Kylie, Blake, and Isabelle. Our first drug is going to be methamphetamines. So the brand name for clinical use of methamphetamine is digoxin. It is a synthetic stimulant that can be highly addictive, and it's often referred to as meth for short. Also, speed, tweak, crystal, ice, tina, or glass. It could be swallowed, snorted, smoked, and injected. And it comes in several different forms, as you can see in the picture below, crystal meth, powdered, or in pill form. It is legally only available through non-refillable prescriptions, which is sometimes used for ADHD, narcolepsy, and short-term treatment for obesity. The physical effects of methamphetamines cause the release and blocks the reuptake of dopamine, norepinephrine, and serotonin. Since meth is a stimulant, it causes increased alertness, talkativeness, confidence, energy, sex drive, a decreased appetite, and other immediate effects. So the effects of methamphetamines can be felt immediately or within 20 minutes, depending on how it was used. The immediate euphoria does wear off very quickly, which leads to a crash, which is usually why people try to avoid the crash by continuous use, often leading to a substance use disorder. Short-term effects of using methamphetamines are paranoia, anxiety, rapid heart rate, increased blood pressure, irregular heartbeat, non-fatal and fatal overdoses. And then the long-term effects are the creation of a substance use disorder, insomnia, symptoms of psychosis, and the development of mental health disorders, decreased cognitive function, and tooth decay, which is also known as meth mouth, which is basically broken or missing teeth and a rotted, dry mouth. It could also increase your risk of stroke, heart failure, and chance of HIV or viral hepatitis. So the final stage of meth misuse is what's called tweaking. So the abuser becomes extremely paranoid and irritable, and it's often because of prolonged sleep deprivation, which lasts about 3 to 15 days. And a quote tweaker is normally unpredictable and may display violent tendencies, commit impulsive acts, and pose a danger to themselves and others. Symptoms of withdrawal. These symptoms peak about 2 to 3 days after their last use, and common symptoms are depression, anxiety, irritability, pain, problems sleeping, trouble concentrating, and intense cravings for meth. People usually feel these symptoms for several months, and the overdoses can be fatal. The CDC shows methamphetamine is the second most common found drug in people who have fatally overdosed. And overdose symptoms are overheating or heat stroke, heart attack, stroke, seizure, and either their breathing slows dramatically or it stops altogether, which is something to look out for. Methamphetamines can also be used with opioids, benzos, or alcohol, so it's helpful to have Narcan on hand as well, as this could be a reason for overdose. So, methamphetamines with mental health nursing, nearly 30% of adults diagnosed with a mental illness also abuse drugs and or alcohol, meth being included in the abuse illegal drugs. Something that's important to consider when treating a patient using methamphetamines is the time of symptom onset. As previously said, it usually peaks 2 to 3 days after their last use. Methamphetamine use is also associated with various health issues like cardiovascular, renal, and oral diseases. It's also included in infectious disease transmission, psychosis, and other mental health disorders. So, when assessing a patient going through meth withdrawals, it is important to also screen and treat underlying health conditions that this patient may have physically, as well as treating any co occurring psychiatric disorders. It's also important to consider the stage of drug abuse that this patient could be in. If they're actively tweaking, they can be a danger to themselves or others, and we may need to provide extra precautions. The same goes for if they are developing psychosis symptoms. In terms of treatment, there is no specific FDA approved medication for methamphetamine use disorder, but medications may be given to lessen the withdrawal symptoms. Medications like Wellbutrin, Prozac, Provigil, and Remeron can be used to decrease any anxiety, depression, or any of those common symptoms. Contingency management is one of the best behavioral treatments that is used. It offers small, tangible incentives like prizes to help keep people from using meth and to continue their treatment. Cognitive behavioral therapy, group support, and motivational interviewing are also commonly used. And for those who are not ready to reduce or stop use, you can still educate on safe practices to help reduce the risk of contracting HIV or hepatitis B and C. Although we really want our patients to stop misusing methamphetamines, there is a long road to recovery and addiction, and that may include relapse. So at least we can provide them with ways to be safe, like not sharing needles and using protection during sexual encounters. And here are my references.
Okay, next we're going to talk about MDMA. MDMA, the full chemical name is that one that I put up there. I'm not going to try and pronounce it, but the common names are ecstasy and Molly. Ecstasy is typically in tablet form, and Molly is typically in a crystal or a powder form. And this drug is commonly used in party or rave settings. It affects a person's mood and behavior by increasing serotonin, dopamine, norepinephrine, similar to stimulants like methamphetamine, but also can be classified as a psychedelic. The physical effects of MDMA are increased heart rate, increased blood pressure, increased temperature, and then also you could see jaw clenching commonly, or sweating or chills, syncope, which is like fainting, nausea, increased empathy towards others. They desire to be like physically closer to the people around them, and there's a like change in sensory perception. The symptoms of withdrawal and overdose for people on MDMA are withdrawal symptoms include fatigue, depression, difficulty concentrating. They have a loss of appetite, sleep issues, anxiety, and they're often irritable. Overdose and toxicity symptoms, serotonin syndrome can be seen. It's not all that common, but it can cause agitation and confusion, sweating, and fever. And then if it's combined with SSRIs, that's when it's most seen because it increases the risk of too much serotonin in the person. And then hypothermia and hyponatremia are also toxicity symptoms. MDMA and mental health nursing. For mental health nursing considerations with MDMA, it's important to note that like it's not used in routine healthcare, although it is now being studied to control in controlled clinical trials to be used for PTSD patients. When a patient first comes in, the priority is to assess their ABCs and their vitals, given that the symptoms are like increased heart rate, increased blood pressure, and the nurse should evaluate the patient's mental status, obtain information about substance use history, including polysubstance use, and monitor for serious complications with serotonin syndrome, as I explained earlier. Patients might also experience mood swings or a come down effect from MDMA, which leads to depression or anxiety. So having that ongoing mental health assessment is essential for these patients just to make sure they're doing okay, and using therapeutic communication, of course, and having that calm, like supportive environment, that milieu, and a not a judgmental approach to help build trust and give like the best effective care. For treatment considerations, there's no specific FDA approved medication to treat MDMA. They haven't like established anything like that, but MDMA is generally considered less addictive than substances like cocaine or opioids. It can still be addictive and can become something people rely on, but it's not as addictive. And mainly to treat it, the patients, you have to give them like more of a supportive and symptom-based care. Benzodiazepine can treat MDMA toxicity symptoms like their agitation and the seizures that can sometimes also occur. Detox programs that provide that milieu environment, support groups, and medical supervision, and cognitive behavioral therapy. as we mentioned earlier, which alters patients' like negative thought patterns and just helps them change their thoughts from thinking about using MDMA to using like an alternative. Those are the references.
Okay, so I'm gonna be talking about um, hallucinogens. These are a group of drugs that mainly affect a person's perception, mood, and thinking. Some of the common examples are LSD, mushrooms, PCP, ketamine, and then MDMA, like Kylie just presented on, is considered a hallucinogen. Um, what makes these drugs different from others is that they change how the brain processes reality. They act on serotonin, which plays a role in mood and perception. And because of this, people can experience hallucinations. So they can see or hear things that aren't actually there, or perceive things in a distorted way. And one important thing to understand is that the effects are pretty unpredictable. So some people could have like a really, really positive experience, or like they could consider like a spiritual experience, or they could have a really, really bad trip with intense anxiety, fear, or paranoia. Um, Physical effects, hallucinogens can have both physical and psychological effects. Physically, they stimulate the body, so patients have an increased heart rate, increased blood pressure, sweating, nausea, dizziness. Yeah, there's the table that has a lot of the different effects. Psychologically, the most noticeable effect is hallucinations, like I mentioned. They're often visual, so patients can see patterns, bright colors, distortions, and then auditory hallucinations as well. Another key effect is the distorted sense of time. Patients might feel like time is moving super, super slowly or super quickly, depending on the type of trip they have. So it can be disorienting. Um, and then with bad trips, like I said, patients can have anxiety, panic, or paranoia. And this can actually lead to unsafe behavior. So it's important to monitor in a clinical setting. Um, Unlike substances like alcohol or opioids, hallucinogens don't usually cause strong withdrawal symptoms, but patients can still experience psychological effects after using them, like anxiety or depression, just based off of like if they had a really, really good trip, they could kind of come back down to reality and be like, oh, I want whatever that reality I had was. One important concept is um, flashbacks or hallucinogen persisting perception disorder, which is total or partial recurrence of perceptual disturbances. It's pretty rare, but essentially the person just kind of like has kind of bits and pieces of this trip in their reality. So like lights could look different for a couple seconds occasionally, I guess. And it could relate back to the trip that they had. Um, with overdose effects, it's less about like the drug being toxic, but about the person's behavior while under the influence. Like I mentioned before, these patients can do some harmful things when, like to themselves or to others, when they have a bad trip. Patients can become agitated, confused, or even experience psychosis, which increases the risk to harm themselves or others. So safety is kind of just the main concern. And mental health nursing, uh, a lot of focus is on assessment and safety. We want to assess the patient's mental status, including whether they're experiencing hallucinations, their level of anxiety, and whether they're oriented to reality. Safety, like I mentioned, is one of the biggest priorities because the patients may not fully understand their surroundings or their actions. So creating a calm, like stable environment, low stimulation environment is super important. Too much noise or just kind of things going on can make symptoms really, really worse. And therapeutic communication is also key, being calm, reassuring, and not judgmental. And then just monitoring ongoing symptoms. There are no specific medications that directly treat hallucinogen use. So being supportive, focus on the patient safety, um, doing things like just hydration, rest, and monitoring vital signs. If a patient is severely anxious or agitated, we can use benzos to help calm them down. For long-term care, therapy like CBT therapy can be helpful, along with education about substance use and relapse prevention. And there are numerous support systems that can really help patients in like group therapy. And these are my references.
Okay, so I'm going to be talking about THC. So THC is also known as marijuana, and it's one of the most commonly used drugs in the US. This is especially among young adults. And in 2021, about 35.4% of people aged 18 to 25 reported using it in the past year. It's taken from the cannabis sativa plant, and the main active component is the THC. And this is what is responsible for the high feeling that people say. And it works by acting as a partial agonist on the CB1 receptors in the brain and the CB2 receptors in the immune system. So it has pretty systematic effects through the cannabinoid system. And this will be affecting the person's mood, their behavior, their sleep, their memory, their appetite, their metabolism, and then pain perception. And many states do allow marijuana for medical use, but these healthcare providers can only recommend it. They cannot prescribe it. And this is because the FDA has not approved marijuana as a treatment for any condition, and it's classified as a Schedule 1 substance. And this means that it has a pretty high potential for abuse. So access, as I said, access to medical marijuana does depend on the state, but it is commonly approved for multiple different conditions. This includes things like chronic pain, PTSD, cancer-related nausea, and many more that I'll get into later. So the physical effects of THC do vary on the way it's ingested and the amount that's taken. The effects can be immediate or they can take within like 30 minutes to an hour. And the effects are systematic. And historically, it was considered a hallucinogen, but it doesn't always produce these effects in the user. And it's generally considered pretty safe, but there are many different side effects that could happen, and there is that risk for addiction. So in this picture, there's some of the side effects, and this includes like increased heart rate, a dry mouth, fatigue, changes in blood pressure, sedation, increased appetite. And then for medical use, it's often used for chronic pain relief, especially for like neuropathic pain, reducing nausea, especially for cancer patients, managing multiple sclerosis symptoms, and acting as an appetite stimulant. And then the long-term effects of THC are still being studied, but there are known risks that include things like lung damage, risk for heart disease, stroke, and vascular disease. And then there are potential impacts on memory. So as I said, this is a Schedule 1 substance, so there's a pretty high risk for addiction. And this is known as cannabis use disorder. And it could range from mild to severe, but individuals that are more frequent users tend to experience more intense and longer lasting withdrawal symptoms. And this is characterized by continued use despite negative effects on the person's health and their functioning. Some of these symptoms include things like cravings, irritability, putting themselves in risky situations, and then developing tolerance. So the withdrawal symptoms typically begin within 24 to 48 hours after stopping, and they peak within a few days, and they could last up to 3 weeks. And for 3 weeks, that's especially in like heavy users. The withdrawal is not usually super severe, and there's not many complications, but often these people are polysubstance users, so it could be more severe then. But some of the symptoms include anxiety, irritability, a depressed mood after, sleep disturbances, and changes in their appetite. And there's a pretty low risk for overdose, but intoxication still can occur. And this can lead to like an impaired judgment and oftentimes indirect fatalities. Okay, so as we know, marijuana significantly affects the person's mental health, and there's lots of mood changes such as euphoria, relaxation, or there could be like anxiety, hallucinations, or paranoia. And long-term or frequent users, they could have issues like depression, anxiety, cognitive impairments, and issues with their memory and concentration. And using THC increases the risk for polysubstance abuse. There's also a risk for worsening of existing mental health conditions such as psychosis, schizophrenia, and bipolar disorder. Also, hospitalizations related to cannabis have been rising recently, and emissions are often due to cannabis dependence, harmful use, or cannabis-induced psychosis. So mental health risks do play a pretty critical role in THC use. And this is a critical role in their education. Screening is very important. It's important to assess these patients. And then, as we've said before, like therapeutic communication and being non-judgmental is super important. Okay, so there are currently no FDA approved medications specifically for treating cannabis withdrawal. So the treatment is mainly focusing on supportive care. There have been a few studies that show benefit from things like gabapentin or buspirone, though they're still not FDA approved. And it's super important to consider benefit versus risk with each patient and individualize this. There's benefit in the medical sense, but there still is that potential for addiction or mental health risks or worsening of existing conditions. So, nurses play a key role in things like counseling and behavioral interventions. This includes CBT therapy, motivational therapy, and in doing this therapy, it could help patients manage things like their cravings, find triggers for use, and develop better coping strategies. And at the end of the day, with THC use, patient education is one of the most important things. And nurses help play a role in teaching about safe use, if it's for medical uses, teaching them about risks, and then teaching them about strategies to prevent dependence or things like relapse and help patients make the best decision about their care. And then those are my references.
Okay, and lastly, I will be presenting on cocaine. Cocaine is a powerful central nervous system stimulant that comes from the leaves of the coca plant, which you can see in the photo on the right. It's typically found in two main forms, powder cocaine, which is typically snorted, or crack cocaine, which is crystallized and can be smoked, although other forms of ingestion are also possible. Crack tends to act faster and produces a more intense and shorter lived high, which significantly increases its addictive potential. So, from a pathophysiological perspective, cocaine works primarily by blocking the reuptake of neurotransmitters, specifically dopamine, but also norepinephrine and serotonin at the synaptic cleft. So, this can lead to accumulation of dopamine in the brain's reward pathways, which can produce an intense euphoria. So at the same time, increased norepinephrine can contribute to the stimulant effects we see systemically, like increased heart rate and blood pressure, which I'll continue on in the next slide. But because of this mechanism, cocaine not only produces a rapid high, but also reinforces repeated use, which leads to the high risk of dependence and substance use disorder. So as I mentioned, cocaine has significant systemic effects, especially on the cardiovascular system, due to its strong sympathomimetic properties. It increases heart rate, blood pressure, and oxygen demand, while simultaneously causing vasoconstriction, which decreases oxygen supply to the tissues. So this mismatch between oxygen supply and demand is what puts patients at high risk for myocardial ischemia and infarction, even in individuals without pre-existing cardiac disease, which is why it's so dangerous. So some of the common physical findings, which you can see in the graphic there, include chest pain, arrhythmia, dilated pupils, diaphoresis, restlessness, and decreased appetite. This chronic use of cocaine can lead to significant weight loss and malnutrition. And then also with intranasal use, which is when you snort it, repeated vasoconstriction can cause ischemia of the nasal septum, which can lead to tissue necrosis and eventually perforation of the nasal pathway. And then neurologically, cocaine lowers the seizure threshold and can lead to strokes due to both vasospasm and hypertension. And in severe toxicity, patients can present with hypothermia, seizures, coma, all of which are medical emergencies. So cocaine withdrawal differs from substances like alcohol or opioids in that it's typically not life-threatening from like a physiological standpoint, but it can be psychologically significant. So some withdrawal symptoms can begin within a few hours or days after stopping cocaine and can be described as a crash. So these can include profound fatigue, depression, increased appetite, sleep disturbances such as hypersomnia or insomnia, and intense cravings. So from a nursing perspective, as I mentioned before, the most critical concern during withdrawal is the major risk for these depressive episodes and suicidal ideation. So as I'll continue on, there's mental status assessments and suicide risk screening that's essential components of care of cocaine withdrawal. And then cocaine overdose, on the other hand, is an acute medical emergency. Excess stimulation of the central nervous system and cardiovascular system can result in arrhythmias, seizures, severe hypertension, confusion, and altered mental status, which can result in a coma or even death. So a key life-threatening complication is sudden cardiac death, which is due to these fatal arrhythmias. Yeah. So in mental health and acute care settings, nursing management of patients using cocaine requires both physiological and psychological assessment. So patients may present with agitation, anxiety, paranoia, or even psychosis during intoxication. And as nurses, it's important to maintain calm, structured, and non-judgmental environment to reduce stimulation and prevent escalation in these patients. So as we take care of these patients, we want to make sure that we have ongoing monitoring of their vital signs, particularly the heart rate, the blood pressure, temperature, and cardiac rhythm, because of this high risk of cardiovascular complications. And during withdrawal, nurses prioritize assessment for depression, suicidal ideation, and overall emotional distress. So that in doing that, we want to support sleep, nutrition, and hydration. And then in a research article that looks at the clinical implications for nursing practice and cocaine addiction, the author highlights the challenges that were faced by addiction nurses and the complexity of cocaine addiction and how the effects on the major body systems really pose a difficulty for nursing. But we just want to make sure that we're implementing interventions that are reducing these health risks and facilitating the recovery. And finally, in terms of treatment, as similar to the other drugs that we mentioned in the presentation today, there are currently no FDA-approved medications specifically for cocaine use disorder. However, pharmacologic interventions might be used symptomatically for things like insomnia, anxiety, or headaches. And because there's no targeted medication, the mainstay of treatment is non-pharmacological. So as mentioned before, things like cognitive behavioral therapy, contingency management, group therapy, and long-term support systems. And nurses play a key role, again, in patient education. We want to prevent relapse in these patients and connect them to resources. And building this therapeutic rapport is especially important because there is stigma around drug use, specifically cocaine use. We want to make sure that our patients are open with us so we can fully assess them and be sure that they're not going to have future complications if they are coming off of the drug. These are my references. Thanks for listening to our presentation.